Yeah. So hi everyone. Uh, is there any disruption from our side in the audio? I suppose it's a no. So my name is Manisha and I work as the coordinator of social work team in Pallium India. And I've been in Pallium for the last 2 years and it's been a great journey throughout. So without much introduction, I'd like to step into the session. So it's really good to see all of you here. And today we have people from different parts of the country. And we have people who have previous experience in palliative care and some who do not have an experience in palliative care at all. And we have people who are working in NGOs, in government sectors, and also people who are pursuing their studies too. So I take this opportunity to welcome all of you to this session, and I hope this is a good platform for you all to learn with us. So today we have one brilliant speaker who's with us. So I'll just give a brief introduction about her. It's none other than Ms. Smriti Rana. So Ms. Smriti heads the Strategic Programs and Partnerships Division at Pallium India, which is an organization that demonstrates, educates, and advocates for the integration of palliative care into mainstream healthcare in India. Ms. Smriti's work focuses on ensuring safe access to opioid analgesics for pain relief in India by engaging with central government and other key stakeholders. She is the liaison officer between Pallium India's flagship clinical program, the Trivandrum Institute of Palliative Sciences, which is a WHO collaborating center for training and policy on access to pain relief, and the WHO Southeast Asian Regional Office for Essential Drugs and Medicines. Additionally, she leads capacity bridging programs for Pallium India through partnerships with other social development sectors actors. She has been a spokesperson for civil society perspectives from LMICs on various platforms, including events hosted by the Vienna NGO Committee and the UNODC. And she was also a part of the experts group that developed the WHO technical report on globally applicable indicators to access and monitor provision of palliative care services. Ms. Smriti works for improved death literacy, appropriate end-of-life care, and for the inclusion of people with lived experience at decision-making fora. She advocates for decolonizing healthcare and is passionate about the role of storytelling in humanizing healthcare delivery. Trained as a psychologist, Ms. Smriti began working in palliative care in 2001, which is almost 20 plus years. She started her journey after the loss of several family members in a quick succession. She is the India advocacy focal point for the International Association of Hospice and Palliative Care and is a board member at the International Drug Policy Consortium. So I know this is a huge introduction, so this is what she is. And without any delay, I'd like to hand over the session to Ms. Smriti Rana. Welcome you, ma'am, and thank you so much for joining us today.
Thank you. Thanks very much for that introduction. And I'm really pleased to be here for the start of a new FCPC program. We designed this program a few years ago with the idea of creating something for non-medical personnel. And over the last three batches, I've come to realize that it is populated by not just non-medical and allied healthcare workers, but also doctors and nurses. And that's really reassuring to me because it shows us that psychosocial care really affects everybody. And I'm really glad that people from different disciplines are interested in it. So my job today is to give you a broad overview of palliative care. And like Manisha said, there are several of you who've already worked in palliative care before. So please forgive any repetitive information. And I'm going to be presenting primarily from the point of view of the work that we at Pallium India do. I'm very acutely aware of the fact that different institutions, different groups of people might have different approaches. What we look at in our practice, I'm going to be taking you through that in just a moment. And I really encourage you to use the chat box to ask questions, to place your comments there, and even reflections if you have any. If there is a personal story that you'd like to share, I will request that you hold that for the last section of the session, because especially if it is a story that is deeply personal and moving in nature, I would feel bad not to be able to respond to it as the session is going on. So I'd really like the time to respond to it later. So let me get started. Let me just share my, can I get screen sharing rights, please? Okay. So here we go. Firstly, before we talk about palliative care, we need to talk about healthcare, because palliative care is a part of healthcare, and we cannot understand it in and of itself without going into the larger context. And health, as we see it, is not just the absence of disease and infirmity, but it is also physical, social, and mental well-being. Very often, we focus on the first part, that health is just the absence of disease. And the end goal of healthcare should be to either eradicate disease or cure it or treat it. And that is the end all and be all. Very rarely do we look at the second part, which is physical, social, and mental well-being. I'm going to stop for a second and ask if this current definition of health has been experienced by any of you in this room. Have you had this experience that, you know, healthcare that you have encountered is not just the absence of disease, but also the presence of well-being, emotional and social well-being as well? And you raise your hands. Please feel free to use the reaction buttons. You can unmute yourself if you have something to say. And okay, so I'm glad to see that many, yeah, well, here come the hands. 2, 3. Okay, 4. That's really encouraging. I'm very happy to see that. Okay, great. I would still say that's what, 4 hands out of 40, but it's something. Okay, so here we are. But here's the truth. India's healthcare is ranked amongst the most unsatisfactory in the world. We come in at 145th amongst 195 countries, and we're not doing very well compared to even our neighbors. Okay, so this is from the Healthcare Access and Quality Index from 2015. Of course, those numbers have changed. All of us are aware that we actually haven't gone very far up the healthcare index over the last few years. There's another statistic that I want to share with you, and this is from the 2014 National Crime Records Bureau of India. Approximately, that figure translates to 1 in 5. 1 in 5 people who chose to end their lives in 2013 were suffering from various ailments like cancer, AIDS, paralysis, and several other things. 1 in 5 people who ended their lives in 2013 were living with a serious illness. What does this tell us? There's no clear corroboration in that sense. There's no evidence yet to show that it's because that they were living with disease, they chose to end their lives. But anyone who is able to apply their mind to this can understand why people chose to do this. Can I request you to use the chat box and tell me what might be the connection between so many people living with serious illness choosing to end their lives? Financial issues. I see someone has said spiritual component is missing. Thank you for pointing that out. It's also spiritual well-being. Yes, so coming back to this, financial issues, hopelessness. What else? What else might prompt somebody living with mental support? So Rajesh, do you mean lack of mental support? Social issues, no support system. Don't want to be a burden on the family. That's a very important one. Great. I'm seeing a lot of responses in the chat box. No support, no palliative care support, unbearable physical pain, helplessness. Yes, I think we've got the gist of it. Absolutely. Now, why would people want to end their lives? I can tell you that in the 20 years that I've been associated with palliative care, I have encountered at least, well, I've lost count. I would say upwards of 20 requests for people asking to end their lives, asking to be euthanized because the pain was so unbearable. And also not wanting to be a burden on their families. That's a huge reason. And the isolation, and there are some diseases that are more stigmatized than others. You might get, support and empathy and sympathy if you were, suffering from cancer. But if you had something more stigmatizing, like HIV or something else, then perhaps you don't get that kind of empathy and sympathy from the family. Just 1 second, please. Sorry. So moving to the next slide, end of life care in India has been described by Dr. Sankamitra, who's one of our associates, as he describes the situation like this: the poor die in misery and neglect, the middle class die in misery of ignorance, and the rich die in misery on ventilators. And no one gets a pain-free and dignified death. While this might be, some of you might have experienced this quite differently, but for the vast majority, this is the experience. And in fact, there's another very senior consulting neurologist, a physician who's a good friend of ours and who will be also talking to you about end of life care in India. He actually describes the current healthcare system as, high-tech hospitals where the poor can't get in and the rich can't get out. And that's something that all of us have experienced at some level or the other. This is not just an anecdotal observation. The Lien Foundation commissioned the Economist Intelligence Unit to do a quality of death index. And this has been done twice over, in 2010 and 2015. And there's a country comparison that has come out in 2021 on death and dying, and the indicators that people have used in order to arrive at this ranking. There are 20 plus quantitative and qualitative indicators, including human resource, palliative care, pain relief, infrastructure, and so on. And in all of this, India ranks 67th amongst 80 countries. 67th. So basically, India is not a country to die well in. And if you just look at the kind of countries that have even got better, who score higher on the index than us. Of course, the top few countries are what we call global north countries, developed countries, and you can see that the lower half of this ranking chain is countries from the global south. But India, where India's place, is actually terribly low down the line. Now, what is the impact of healthcare? And I've put health in italics because if we talk about health being not just the absence of disease, but also the presence of well-being, the way the current healthcare system is structured in India actually leads to catastrophic out-of-pocket healthcare expenditure, which then leads to people being pushed below the poverty line. And this is a report that came out in 2017 that 55 million Indians are pushed below the poverty line every year because of healthcare expenses, of which 38 million Indians are pushed below the poverty line because of just the cost of medicine. What does this say to us about a healthcare system that inflicts further suffering rather than take away from it? This is not how well-being is achieved. And some of you also talked about the fact that the suicide statistic is related to financial problems. This is what we're talking about. In trying to get treatment, people sell their homes, they mortgage their properties, education gets disrupted, all kinds of things happen. And the suffering of the illness of one person results in the suffering of the entire family, and also results in some cases in multi-generational debt, where the family is paying off debt for generations to come. I'm going to take a minute to spend, I'm going to spend a minute on this slide. Astana Declaration. The Astana is a place in Kazakhstan, and this is where in 2018 this declaration was made. And this has to do with universal health coverage as well. Quality healthcare should reach people where they are, when they need it, at an affordable cost. Let me repeat that. Quality healthcare should reach people where they are, when they need it, at an affordable cost. So it's talking about quality, it's talking about accessibility, and it's talking about affordability. And secondly, the second important part of that declaration was that health for all has to be health with all and include people in designing and controlling healthcare systems. So what this says is that in order for healthcare to be truly contextual and appropriate, the people who are recipients of healthcare should be involved in the decision-making process as well, because one size does not fit all. Now, these two are very utopian and lofty statements and declarations. We are nowhere close to achieving this. But hey, it gives us something to aspire to, so that's something. The reality, which is so far from that utopian declaration, is this. I'm going to just let you sit with the story for a minute. We heard about this this happened in 2016, where some of you might actually remember this. This was in the newspapers. I'm going to let you read this for a minute. Okay, so you've had a chance to read this. So basically this couple, they made the news because they had moved the court to make a request to euthanize their son. The son was 4 years old. And why did they want to euthanize him? Because his pain was unbearable for them to watch. Of course, the plea was not granted. And when we read about it, several palliative care organizations across South India mobilized to try and find this family. And it was very difficult to find them, but finally they were tracked down to an ICU in a hospital in Bangalore. A social worker carried opioids that were prescribed by a pediatric palliative care physician in Hyderabad. She traveled with those opioids overnight by bus to Bangalore, but she was never allowed into the hospital, into the ICU. The child was never given the medication, and he died a terrible, terrible death in excruciating agony. And in fact, that social worker took quite a long time to recover from that whole experience. I wish I could say that this was a one-off. This isn't. There is another horrendous case from Kerala itself, where a couple actually took their own lives after killing their child because they couldn't bear the agony of their child. I mean, the kind of pain that drives parents to do this to their children must be agonizing, unbelievable pain, right? I often get asked, how bad does cancer pain really get? I've had a ringside view to it because of a lot of rampant cancer in my family. And I can tell you there comes a time when you just can't bear to see that person in that level of pain. And I'm sure there are many in this audience who've had the similar experience. So what is palliative care? We've talked about healthcare. Let's talk about palliative care. Firstly, for those of you who are here, just getting introduced to palliative care quite literally for the first time, you must have heard quite a few things about palliative care that unfortunately serve to limit people's access to it. Or these are myths about palliative care that actually deter people from reaching out to it. The first of those myths is palliative care is only for people dying of cancer. Most people believe that this is what palliative care is. It's only for people dying of cancer. The fact is that palliative care can benefit patients and their families from the time of diagnosis of any life-limiting or life-threatening illness. It is not only for cancer. It does not benefit only the patient, and it's not only for end-of-life care. You can actually get a palliative care team involved right from the start. Yes, their role becomes a little bit more important towards the end, but there is no reason for them to be not brought in right at the beginning. Now, unfortunately, palliative care has this reputation of being end of life care because either referrals come to us too late, or it's out of desperation when nothing else, no other curative treatment works, that people are seeking something, that they come to palliative care. And that is what has made this myth much worse. And a lot of people, because of this myth, it's a self-fulfilling prophecy, because people who could benefit from palliative care don't ask for it because they believe that they're giving up on cure. The second very pervasive myth is that, which I just said, palliative care means giving up and there is no more hope for me. So it's the loser's way out in a lot of cases. That's how it's perceived. And you'll find a lot of doctors also, perpetuating this myth, because I've heard of attending physicians telling families, yeah, but you're not there yet. Your father doesn't need palliative care yet. You're not there yet. And I wonder sometimes what yet or what there is. How much pain does someone have to be in order to get pain relief? How much distress does someone have to be in? And the thing is, palliative care can very easily be done side by side with curative treatment. It is not an either or situation. And in the case of palliative care, hope is not about futile interventions and cure, but more about living a life of quality as fully as possible. Okay, so what we are not doing in palliative care is not stopping everything, but we're stopping futile interventions that will maybe give you a few more days, but is not going to give you a quality of life. You're going to have certain statistics and blips and numbers showing up on the monitor, but is that quality of life? No. So palliative care is about quality of life rather than quantity. But that doesn't mean that we want to hasten death. And that's the other myth. Palliative care hastens death. No, it is not something that hastens death. And in fact, it provides comfort and the best quality of life from diagnosis of an advanced illness until the end of life. And there is enough evidence out there, and you can find this in journals and things, of how when people receive good quality palliative care, their lifespan increases actually, because suddenly they're able to re-engage with life in a meaningful way. They have a sense of well-being, what we talked about. It's not just the absence of disease, but the presence of well-being. And when there is a sense of well-being, people automatically start feeling a little bit better. They might actually find healing happening to them in unexpected ways. Pain is a part of serious illness and dying. Now, this is something that a lot of people believe that, hey, if you have a serious illness, you're bound to be in pain. There's nothing you can do about it. And the thing is, palliative care believes that pain does not have to be a part of illness and dying, and it can be alleviated. This is sort of exacerbated by the fact that until 2019, pain management, physical pain management, and palliative care was not there, but even physical pain management was in total amounting to about 1 hour in the MBBS undergrad curriculum. And what I'm told is that it was a non-examinable subject. So if you're not going to be scored on that, then the message you get is that it's not a priority, no? So let's focus on the surgeries, let's focus on the treatment, let's focus on all these things. But pain management, not important. Then 2019 is when the Medical Council of India introduced pain management, end-of-life care, and something called AIDCOM, which is Attitude, Ethics, and Communication, into its undergrad curriculum. That was 2019. Now, who's going to teach it is the new question, because previous trainers were not really taught it anyway. So there's a movement underway now to get that also going. So no, pain does not need to be part of serious illness. There are ways to alleviate pain, and we must explore it. There is a belief that morphine is administered to hasten death. Morphine doesn't hasten death, and appropriate doses of morphine actually keep patients very, very comfortable. Taking pain medication in palliative care leads to addiction. This is a huge barrier to palliative care, because people believe that the use of opioids, which is basically narcotics, leads to addiction, and therefore you don't want that for the patient. But the thing is, again, appropriate doses of morphine and other opioids used with training and understanding do not lead to addiction. And I will talk about that in a minute in more detail. So one of the biggest misconceptions is that morphine is definitely going to lead to addiction. That's not true. So if I were to give you a snapshot or a summary of all of this, this is what it looks like. This is when disease is suspected. This is when it is detected and diagnosed. And then it advances and there's death and bereavement. And this is palliative care. At first, it's curative treatments and interventions that really take center stage. But as we get closer and closer to advanced disease and death, yes, palliative care becomes more relevant. And unfortunately, this is usually where people are referred to palliative care, when it's too late for us to even really establish a rapport with the family or to help. I mean, we might be able to help them, but it's literally at the very end. So the process itself also looks like this. You have a life limiting, and please remember, I'm not saying only life threatening, life limiting illness or life limiting conditions, which also include disability, which also include congenital anomalies. It could include many things. When that advances to a terminal illness, and then you have a pre-active dying stage where the person is starting to show signs of deterioration, and there is something that we call active dying, when the person is when the system is shutting down, and there are ways for us to recognize when active dying is taking place. I'd also like to just mention here that the need for palliative care is much higher in countries like India and other low and middle income countries as compared to the West, because disease specific treatment does not reach us adequately or in time. And therefore, people who would not come under palliative care treatment in other countries require palliative care in countries like ours. And I'll illustrate that with an example further down the line. This is a very important concept in palliative care, and I've actually not heard it anywhere else except in palliative care circles. And it's the idea of total pain. Total pain is when a patient reports his or her subjective pain on the pain scale. The pain scale is a scale of 1 to 10, where 0 is no pain and 10 is excruciating pain. And I ask you, on the pain scale, where are you? And what total pain says is that it is important to remember that physical pain reported by a patient is compounded or made worse by his or her current life circumstances. So I'm going to really just take this moment to demonstrate to you what I mean by that. 1 second. Okay, anyway. Okay, so I'm going to ask you to just sort of imagine the scenario where you have a headache, okay? And maybe it's a Sunday, and so you get to be at home, you're with your family or with friends, and you're relaxing, and you have this headache coming on, but there is somebody there to look after you. Okay, so they say, don't do anything, just relax, go lie down. What do you want? Do you want soup? Do you want tea? What do you want that I can bring you? And anyway, you're being taken care of, you get to take a nap. And so on a scale of 1 to 10, how much would you rate that headache? You can use a chat box, you can hold up fingers. How much would you rate a headache like that, which is a general headache that comes once in a while? 4. Okay, I can see it's all in the middle or to low ranges, right? 2, 3, 4, 5. 5 being the highest is what I'm seeing. Most of them are 2s and 3s. Okay, same headache. Monday morning, late for work, miss 2 deadlines. You have a boss who's really angry with you. On the way to work, you have a flat tire and you don't have a spare tire. You forgot to fix it the last time. You're getting call after call after call from your workplace. And you suddenly remembered that you left the geyser on at home. And then someone's calling you from home and shouting at you about that also. What's the pain scale now? I can see the 9s, 10s, 8s. All right. Okay. Yeah. There you go. Ranjan, did you want to say something? Do you want to unmute? Or is that a 5 score of 5? All right. So this, my friends, is total pain. But a very, very, very trivialized version of it. Okay. So imagine this headache magnified by 1,000, and imagine what cancer patients and other people experiencing pain go through. And over that, think of the fact that they don't have money to pay their treatment bills. They have to pull their child out of school. They have to find alternative arrangements for travel to go somewhere to get the treatment that they need. All of those things, right? Where's their pain going to feel? Now, if you want to treat that pain, your painkillers alone is not going to work. You're going to have to mitigate the suffering around them, their life circumstances, make it better so that that pain comes down. So palliative care is not just physical pain management. It is all of these things. And I'm going to just come back to my screen now. Okay. Illness-related suffering is much more than physical distress. There's a physical component, of course, which could be the headache, which could be the pain, which could be the breathlessness. There's a psychological component of how the person is experiencing the illness. So the physical part is the disease, the psychological part is the illness, and the kind of meaning that the person gives the disease, how the disease has impacted them psychologically. Has it made earlier difficulties worse? Families that are dysfunctional tend to become more dysfunctional when a crisis hits. It causes anxiety, it causes all kinds of things. Socioeconomic, it affects you in terms of your finances, it impacts you in terms of your status in society, the amount you're able to continue to engage with the community around you. And of course, there is a spiritual component to it. And by spiritual here, I don't mean religious. I mean, religion is a part of it. But what I'm really talking about here is a meaning, hope, connection, purpose, all of those things. And disease and illness actually really deeply impact the spiritual component of a person, what they find meaning in. There might be people who cannot find meaning in this experience, or they question their faith. They lose connections, they lose hope, they lose a sense of purpose. Or some people might find a sense of purpose. So it's not always a negative thing. But anyway, illness-related suffering is much more than physical distress. And all of these different things together come together, and they form the idea of what we call total pain. So what palliative care is really trying to do is deal with total pain. Very, very quickly, I'm not going to spend a lot of time here, but those of you here who are doctors, and I know that there are quite a few of you, are very familiar with medical ethics. And just to quickly touch upon the ethics framework, for those of you who are not familiar with it, there are 4 medical ethics: autonomy, beneficence, non-malfeasance, and justice. Would anyone like who is familiar with this, would any of you like to unmute yourselves and just take us through what these 4 ethical components mean? Anybody? No one? Autonomy is the ability to determine for yourself what is best for you, and your ability as a human being to influence and impact your environment and your treatment, or whatever it might be. I'm talking about it from the context of palliative care and healthcare. Beneficence is to do good. Non-maleficence is to do no harm. And justice is, especially in the context of social justice, is fair allocation of resources and equity. So social justice is about equitable distribution of resources to the people who need it. Now, these are again 4 pillars of ethics, but it's very, very, like it says on the side here, in theory and practice are the same. Okay, this is the theory, but in practice, they are not. So it's all very well to talk about autonomy and doing good and doing no harm and justice and stuff, but very often these medical ethics are violated on a regular basis, and it's become so regular that we don't even notice anymore. Okay, so I'm just gonna share with you a video. Now that I've given you some sort of introduction to palliative care, I'm going to share a video with you very quickly. I want to tell you, this is more of a Western take on palliative care. I will come to a more Indian contextual take in just a moment. One second. You need to tell me if the sound is all right. Sorry about that.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious...
So did that video help? I think that gives you some sense of what palliative care does. But again, this is a Western take on it. Okay, so eventually I'm going to, like I said, share with you something that is more contextual to our settings. Let me just come back to the slideshow. Okay, so we know now what palliative care is, but why? Why should we have palliative care? So this is typically the usual model where you have the person and then you have the healthcare system, and there's a distance between the two. And like I said earlier on, a lot of healthcare systems nowadays are like fortresses. The poor can't get in, the rich can't get out. So how do we bridge this gap? Now, the second declaration that the second point of the declaration of Astana that I shared with you is that for health systems to be truly effective, you have to bring in the community, and people have to be part of the design and implementation and delivery of healthcare. And this is where, especially in palliative care circles, some of you might be familiar with this, the Kerala model. The Kerala model is celebrated worldwide as the most successful community-based palliative care model there exists. It's another story that it hasn't been replicated yet. But that's all right. I think more and more we find that it's not about replicating the Kerala model. It's about translating that kind of model into your own settings. So whether you're here from Chhattisgarh, whether you're here from Assam, whether you're here from Delhi, you don't have to think about only the Kerala model as being the only model, because the real strength of a model like this, a community-based model, lies in the community. What are the strengths of your community? In Kerala, of course, there was a huge network of volunteers that were trained, and they became our hands and eyes and ears in the community. But perhaps a different kind of model can work for you. There's an incredible new model also emerging in Telangana, where 33 districts have enlivened palliative care. And again, it's through great partnership with the government as well as civil society and NGOs and communities. But anyway, so this is the Kerala model, where to bridge this gap between the micro and the macro, we have the meso, which is the community. And this is what I'm just going to share with you, some snapshots from our model. What you're seeing here is a link center. And this is how our home care program works, that each of these villages or panchayats that we serve, there is a link center, and the link center could be any public service building or any publicly shared infrastructure. In this case, it's a school, it's a primary school. That school becomes the link center in that sense, where our team goes few days a week, and people from the community who need medicines, etc., they come there. Now, this is for people who can move about, who have caregivers, who are mobile, and so on. There are many people who are not able to come to us, but we go to their houses instead. But the link center is where volunteers actually maintain a register, and volunteers are trained to identify when somebody has palliative care needs. And when they say, hey, you know, that old lady who lives by herself, or this young man who recently had a bike accident, they might benefit from palliative care, they come and put the names down in the link center register. And that way our teams then know who to go and meet. And so the link center is really the nerve that connects us to the community. And So this is one example. And like I said, there are people who can't make it to the actual link center, in which case the team then goes to their homes. And very often you'll find that these are roads that are unmotorable or very long distances where there's no public transport nearby. And what you're seeing here is a nurse who carries the medicine. This is the volunteer from the community. This is Dr. Raj Gopal, if some of you might some of you might know him, and a couple of other volunteers from our side and a social work. And we go, again, if you look at the first point of the Astana Declaration is good healthcare should reach people where they are when they need it. Not everybody can come to a hospital. They are sometimes in their homes and they need care in their homes. So we take care to them. So where they are, when they need it, of a good quality and affordable. All our services are free of cost. And that's not to say that that is the only model. Of course, you can come up with cross-subsidy models as well. Now, what you're seeing here is a story that I witnessed. This young man had been in a road accident when he was in his teens, and he was asked to come to the hospital at least once a week, and if he could, at least twice a week, to do some physiotherapy for him to regain mobility and function. He couldn't go. When we found him 3 years after his accident, he could barely move. And why could he not go? Because he didn't have a father. His mother was working in the fields. She was his only caregiver. He's not a small built person. He's quite tall. He's not lightweight. And they live in a little house. This is their house, in a little house on top of a hill, where the nearest road is down that hill, up another little hill, down the hill again, and then the road. This boy can't even get off the step of his veranda. That pathway is not wheelchair friendly. For him to go to the hospital meant 4 people from the village needed to take the day off, or at least a few hours off, come to the house with a khatia or some makeshift stretcher or a chair, put him in it, carry him up and down those 2 hills, go to the main road, where the mother would have to flag down an auto rickshaw, which would cost her at least 300 to 400 rupees one way to take him to the hospital. That's more than her daily wage. So you can see why this boy never made it to physiotherapy, right? He doesn't have a life-threatening illness. He has a life-limiting condition. But a life-limiting condition like this can very well become a life-threatening condition if it is not given the kind of care that is needed. And when I say life-threatening, I don't mean just physically. This boy could have very easily been a candidate for suicide. So a life-limiting condition can become a life-threatening one in that sense as well. So finally, when he was registered with our link center, our team started visiting him. And well, if he couldn't go to physiotherapy would go to him. And we used this mechanism to tie up these 2 poles in his house. And I'm very pleased to tell you that this boy is now quite a lot better. He's much more mobile. His cognitive function is even getting better. But I wonder what would have happened to him if the home care team had not been alerted. In Western universities, they have come up with this great word, this great phrase called reverse innovation. Reverse innovation is when low cost in resource poor settings, we do jugaad. You guys know what jugaad means, right? So reverse innovation is basically another word for jugaad, where you do high-tech interventions with very low cost equipment. Also, I mean, that's one way of defining reverse innovation. I'm thinking, why is it called reverse innovation? It's quite innovative in and of itself, and it serves the purpose. In this case, these set of paddle bars serve the purpose. In addition to medicine, we realized that giving away free medicine, free interventions really doesn't help anyone if they're starving. If a family doesn't have food to eat, what good is medicine? So at least 100 plus families today are being given free rations, food kits by the organization because they need food. And why don't they have food? Maybe the breadwinner is sick. Maybe it's an elderly person living alone or 2 elderly people living alone with no income. Could be various things. So food is important. So you're seeing this man carrying the monthly dry rations to the house while the nurse carries the medicine. Spirituality, would you consider that spirituality, where we talk about meaning, hope, purpose, connection, also has a lot to do with who you think you are and how you meaningfully contribute to society? If I were to ask you today, who are you? Who are you? How would you introduce yourself? You would introduce yourself by your profession. You might introduce yourself as a parent, a brother, a sister, a role that you play in the family. But what if disease takes away those things from you? Then who are you? It's really important for spiritual well-being. Somebody talked about spiritual well-being, that people have a sense of purpose, and how you engage your time, how you spend your time is part of that, right? So in some cases, we have a lot of women with children who have congenital anomalies, and there's a significant number of these women who are abandoned by their families because they believe that they are cursed or because of superstition. And so suddenly you have a young woman with a sick child with high dependency needs, abandoned by her family. And she can't go out to work because she's got this child with her. So what do? You do vocational rehabilitation, and you allow her to at least do something at home that will bring her some income, right? While keeping her meaningfully engaged. The person that you see here on the right, he's somebody with paraplegia, and he chose to make umbrellas. And this is Kerala, so we always need umbrellas here. So this is how he stays engaged, and this is how he also contributes to the income of his family. Children are a big part of the work that we do. And like I said, there are children living with non-cancer conditions. This is somebody with juvenile rheumatoid arthritis. He's been in our program for now 8 years. And we have children living with, chronic kidney disease, again, Down syndrome, cerebral palsy, etc. And all of them are beneficiaries of palliative care. Again, you will not see, these are not patients that you will see in the palliative care program in other countries. But why are they needed here? Because they don't have the appropriate kind of care that they would have gotten anywhere else. One of the biggest casualties of serious illness is a child's education. In order to pay for treatment, very often children, and very often the girl child, is pulled out of school, so that money that is used for education is then rerouted and reallocated for treatment. What does this do? It ruins the life of a child or a young person, even though it's not their fault. So the disease, again, of one person has multi-generational impact on opportunity, on various other things that get completely derailed. A person who is well on his way to doing well in life suddenly is derailed from that path because somebody in his family is sick. So under our Kuti Kutam program, we sponsored the education of children from disease-ravaged families that have been impoverished by treatment costs, and because of which their children have had to drop out of school. We ensure that the child does not drop out of school. This is also palliative care, because this is what serious health-related suffering can do. Elderly people living alone, particularly, are highly vulnerable. And Kerala alone, as of 2014 or 2011, had over 1,76,000 elderly people living alone, of which 1,40,000 plus were elderly women living alone. And that kind of, not only are they at high risk for illness, but also for the loneliness itself exacerbates the disease trajectory and the illness experience. So we've talked about all these different things, what palliative care is, how it is important, why we need it. And now I'm just going to spend some time with you talking about awareness and why it's important for us to talk about palliative care. One is, of course, to bust all those myths that we talked about right in the beginning, right? Palliative care is only for terminally ill cancer patients. Palliative care is only a last resort option. It's either cure or palliative care. The drugs used in palliative care can cause severe addiction. So all these myths, we need to really dismantle these myths so that more and more people actually ask for palliative care and benefit from it. And their families don't have to watch them suffer those, in that horrendous way. So this brings me to one part of the work that I do, which is ensure that we have a seat at the table. This is a very important quote. If you're not at the table, you're probably on the menu. This means that if you're not part of the decision-making process, then decisions get made for you, and then you get chewed up and spat out. So if you are not represented at decision-making forums, then the decisions that come out of those forums are not to your benefit. And this is something that we see over and over and over again in the international, arena, where decisions are made in Geneva, in Vienna, in countries that we don't have diplomatic missions at, where people from lower middle income countries cannot even afford to buy a plane ticket to go to. And these are decisions that are made there that are supposed to be good for those of us living in what we call the global South. So there's a report that came out in 2018 or 2015. This is the Lancet Commission on Global Access to Pain Relief and Palliative Care. This is a map that they came up with. This pretty much became the signature of that particular Lancet Commission. This map shows you the consumption of morphine across the world as per the needs met. How much morphine they need and how much morphine they get. Okay. And morphine, by the way, for those of you who are not aware of it, is the only proxy indicator for a country's palliative care provision. Because palliative care looks so different across different regions in the world, the only common denominator that is now seen as a proxy indicator for palliative care provision is the amount of morphine consumption that are morphine equivalents. So all the opioids that, there's a calculation that you can do, the morphine equivalence consumption across the world. You see that Canada, USA, Australia, they're inflated. They get 1,890% of their need is met. USA, of course, has an opioid crisis. 3,150% of their need is met. India has disappeared. I would say less than 4% of India's need for morphine is met. That means less than 4% of people in pain who would benefit from morphine actually get it. And this is a travesty because India is one of the largest manufacturers of legal opium in the world. So if you look at the countries that have disappeared, and Western European countries are considered to be the benchmark. They're the ones who are really striking a decent, healthy balance. But if you look at the countries that have absolutely disappeared off this map, it's always the erstwhile colonies and the global South countries, the underdeveloped countries or the developing countries. So this is actually a snapshot of the inequity that exists in pain relief. This is what some of us call the cartography of pain. This is what pain looks like globally. And here's a statistic for you. 75% of the world remains without access to proper pain relief. Asia's morphine per capita consumption is 36 times less than the global average. 36 times less than the global average. So 61.5 mg is the per capita consumption of morphine globally. India's is 1.7 mg. Asia's is 1.7 mg. These are also countries where suffering is rampant. These are countries where healthcare systems are not robust. So it's a double whammy. You don't get the healthcare you need, and then you don't get the pain relief that you need. The Narcotic Drugs and Psychotropic Substances Act, which all of you now might know thanks to Aryan Khan, NDPS, was an act that came into being in 1985. It came in as a direct result of the rhetoric on the war on drugs. And suddenly there was this massive thing that, we're gonna fight a war against drugs. And every country had this ripple effect response where they came up with absolutely prohibitive laws, and India came up with the NDPS. In the time since 1985, the morphine consumption went down from 716 kgs to 18 kilograms in 1997. In just 12 years. there was a 97 drop in access to morphine because of how ridiculously prohibitive this law made it for us to access pain relief. And what that really tells you is the pain burden in the country went up by that much. I want you to really understand what this means. For any one of you who have experienced the kind of pain that cancer patients go through and some of the other, other conditions inflict on human beings, to be denied pain relief in a country that actually creates the raw material for the rest of the world is just, it's beyond cruel. Now, for 19 years, the palliative care community, along with champions across civil society, 19 years we advocated for the NDPS to be amended so that morphine for safe medical use becomes available. And it took 19 years for the law to be amended in 2014. In 2015 is when the rules became operational. And some of my colleagues will tell you later in the course of this session how effective or ineffective that has been. Because while the law was amended in 2014, in 2022, only 5 states have a palliative care policy. And in some states, it's still a paper tiger. Okay, taking you from a local lens to a macro lens globally, the principle of balance is something that we talk about a lot. The 1961 Single Convention on Narcotic Drugs, this is by the International Narcotics Control Board, which was brought into existence to really, monitor and control the movement of drugs, of narcotics across the world, very clearly said that we as member states, all countries who are part of the United Nations, have a dual responsibility. First, to prevent abuse of opioids, but secondly, to make opioids available for those in pain. I'm paraphrasing. The actual wording is something else in terms, it's to prevent abuse, misuse, and diversion, and to make accessible for medical and scientific purposes. So this is what it would look like if everything was in balance. This here, this purple line is public health. So you have international laws of criminal justice that say that we have to prevent the diversion of medication and drugs for illicit use. And then there's international laws of human rights that say we have to make some of these drugs available for medical and scientific purposes. But I will tell you that this is tilted more in favor of prevention and control rather than access. And it is very obscenely tilted to that side. So we're always looking at control, we're never looking at access. What is the impact actually if we were to make that balance, if we were to balance those two scales? This is a man who was living with cancer pain and spent most of 3 weeks in this position. He was in such agony. He was one of those people who probably asked to be euthanized. And 3 weeks in this position, but 3 rupees worth of oral morphine enabled him to get up, sit up, and have a cup of tea for the first time in minutes. Now, this is what oral morphine can do. And I won't get into it right now, but oral morphine, if used correctly, can be used very, very safely because you're ingesting it. It's not giving you a rush. You're not injecting it directly into your bloodstream and so on. But why was this man forced to be in that position for 3 weeks when we had the resources available all along? And let me tell you that a lot of these families, and I'm one of them, when we experienced all those excruciating years with people in our family who were sick, and I personally went through a time when 6 people in my family died in the same year, all of them in excruciating pain. I discovered palliative care soon after. For people like me and a lot of these families, discovering palliative care is not an epiphany. It's not a joyful epiphany. It actually is enraging. Because the fact that something like this has existed all along but been denied is very, very hard for a lot of people to digest. So I'm gonna skip this slide. So coming back full circle, a good health system delivers quality service to all people when they are where they need them. And that is what we strive to do. The last couple of things I want to just share with you about palliative care is And some of you are familiar with the idea of clinical decision making. But for those of you who are new to this, this is a very important aspect of palliative care. There are three kinds of communication that you will encounter in healthcare. One is purely medical, where you get information. This is the disease, these are the treatments, and just plain data and stats. You might have a more paternalistic kind of communication where you have information and recommendation. And I don't mean paternalistic in a bad way. Okay, so there is information. Here's the disease, this is the treatment, recommendations. In my opinion, this is what has shown the best results. Evidence suggests that this course of treatment is the best course of treatment, things like that. So there's information plus recommendation. And here's something that we all need to work towards, which I think to a large extent palliative care does quite well. Shared decision making, where you give information, you give recommendations. At the same time, you take into consideration the values and preferences of not just the patient, but also the patient's family. Now, I might give you information about cancer and its best course of action in terms of interventions. I might tell you what has worked for me or what I think has worked for a vast majority of people. But then I need to stop and ask you, does this work for you? The best interventions may be absolutely out of your reach financially. Are you willing to pull your child out of school, sell your house in order to try an experimental new drug that costs the earth? That's me asking for your values and your preferences. Would you like to have this intervention done? Because, in terms of these are the outcomes. So information, recommendation, values and preferences, this shared decision making is where we really need to be. And I think this is really drilled into us in palliative care, that in order to set the goals of care, you have to have that conversation with the family. And very often you'll find that there is collusion. We will be talking about collusion where the family doesn't want you to talk to the patient. But by and large, shared decision making is what we're going for, where we take into consideration what is important to the family and to that patient. Now, just to tie it all up, in the large scheme of things, we are a long way from good palliative care, robust palliative care service delivery in our country. In order for palliative care and pain relief to really happen, we need policy where we have fit for purpose, smart output indicators. Now, why do I say output indicators? Because policy cannot just be, oh, let's just have a national program for palliative care, or let's just make sure there's legislation. We are not the kind of country where just because there's a legislation, it's going to work like clockwork. So in some countries, it's enough to have an input indicator. Have the policy, have the legislation, everything will follow. No, but in countries like ours, we need to know, has this worked? So policy, it has to be smart, it has to be contextual, it has to be appropriate. You have to have education of professionals, politicians, and the public. The education is not just for doctors and nurses. It is also so we talk about education and training and policy and access to medicines. But if you or the lay people don't demand for pain relief and palliative care, none of that will come to happen. So education is important. Busting those myths is important. And finally, demand, increasing demand in the community, right? Civil society, community, and people with lived experience. You're going to hear that phrase quite a bit in the series of lectures that the FCPC series brings to you. People with lived experience. These are really the experts. These are people who have been living with life-threatening, life-limiting illnesses and their caregivers. In my opinion, no one is a bigger expert than somebody who has gone through this. And they're also one of the most powerful groups in terms of advocacy for change. So what do we need in order to have a robust palliative care delivery system in our country? We need a large tent where public, the policymakers, the professionals, and the private sector come together. And which is why I'm so thrilled and delighted to see the demographic and the mix of people who are in this room today, because there are people from each of these different domains here. And we have to tie up the local, the national, and the international. The community, at the community level, what is being delivered has a huge, is hugely impacted by what is going on at the national level. internationally decisions that are being made, the table where decisions are being made, we need to ensure that, there is some connect here. You can't have just policies that are cerebral and good in theory and just not translatable at the local level. And all of this requires our perception together about palliative care to change, that it is not just for terminally ill cancer patients, but it is for anybody and everybody who lives with a serious illness. I'm going to finally end with one last video. And let me see if I can get this straight this time. Just give me a minute. Oops, sorry, just 1 second. This is the video that I believe is more contextual to our country and our setting. I'd just like to say that this was made by the African Palliative Care Association. And I think it really captures what palliative care needs to look like in a low resource setting like ours. So I'm going to stop with that. And if any of you have any questions, any comments, any reflections, now's the time. Please feel free to just unmute yourself and speak up if you feel like you want to. Yes, please go ahead.
Yeah, ma'am. In the second slide or third slide, you mentioned about quality of healthcare, which is in India, which is behind China and Bangladesh. So what are the metrics which are considered to be the quality of healthcare?
Oh, the metrics. What I can do is I can share as learning material. I can share the document with you. I don't have that information off the top of my head at the moment, and I don't want to be inaccurate in what I share. But certainly I'll be able to share that with you after this session, if that's all right.
Right, ma'am. Thank you. Now, ma'am, you were saying something about the Telangana, the palliative care work which is being going on there. Could you tell me something, because I hail from that region?
Okay, wonderful. So there is Dr. Gayatri Palat, who is from MNJ. She works with the MNJ hospital, and she, along with a few others, also run this NGO called the Pain Relief and Palliative Care Society. They have been doing tremendous amount of work in Telangana to work with the government in order to train and build capacity in frontline workers, especially. So in the 33 districts now, you have palliative care access in terms of IP, OP, and home care. So people who come to MNJ as outpatients or as patients admitted there are referred to the palliative care department. Those who need more extended or more intense care, are transferred also to their the hospice that they have through the Pain Relief and Palliative Care Society. And of course, there's a team that goes out into the community and meets people in their homes. So it's a really, really holistic model. And they're also one of the front runners in India today with pediatric palliative care. So we will be happy to share more contact details with you. In fact, if you just look at our website and go to the directory, you should be able to find MNJ. It's also a training center.
Yeah, ma'am. I'm aware of this MNJ Cancer Hospital, which is at Red Hills, Hyderabad. But that is primarily a cancer hospital. But when we talk about palliative care, it is not only cancer, but it is a life-limiting disorders. So I think whether stroke or any other conditions, whether are they working on it, ma'am? Because according to my knowledge, they have been focused on only oncology, onco care.
I'm not too sure about that, because I know for a fact that there are patients with neurological issues and other issues that have been referred to their team, and the Pain Relief and Palliative Care Society does look after them as well.
Okay, ma'am. Okay.
Yes, Abhijit?
Yeah,
Hi.
hi. I was on the volunteer training program. I think that happened a year or two back, and I had registered for this one immediately, but there was some breakdown in the communication. So I think finally connection happened, and I'm happy to be here. Uh, I I regret not being able to carry the flame forward in terms of making a local group of people who are interested in palliative care and all that, but I hope to do it now. The presentation was really nice and very encouraging. Yeah, thank you for sharing so many of your personal details also. I just wanted to know what is the state of palliative policy in Maharashtra? Like, how is the Maharashtra government responding, and what can be done on the state level if there are volunteers like me wanting to push it? Yeah.
Thank you, Abhijit. Thank you, firstly, for such a warm, for just being so warm. And I'm sorry that it took so long for us to connect on this FCPC program, but you're here now, and that's great. Yeah. With us today is also Sunanda. Sunanda is one of our national outreach officers. Sunanda, may I request that you come in and please help us answer Abhijit's question?
Yeah. Hi Abhijit, I'm Sunanda, working as regional coordinator for Palliative India, looking after the central zone, and Maharashtra is one of the states that I'm looking after. So the thing is, as per your question, we are still struggling. I'll say that I have met the NHM, the National Health Mission Director and all. I had a meeting, and we are trying to figure out how to implement this and how we can go ahead. We are still lagging behind in terms of this, and also we are yet to contact the Drugs Control Office to talk about opioids accessibility and all that. So I'll get in touch with you if you need to know more. So once we are done, when we are progressing and we get to know something in detail, we'll share with you. So if you can just send your email ID or anything in the chat box, I'll keep a note and get in touch with you. Thank you.
Yeah, thank you. It doesn't work with the delegation meeting. These things don't lie in the hands of the chief minister or anything like that. That you directly meet him.
Please go ahead. Yeah.
Sorry. Yes, because health being a state policy, finally it's implemented through the state governments. So you can have the policies, the programs, the guidelines in place at the central level, but it is the onus of every single state government to actually implement it, and to what extent they implement it is entirely up to them. Now, under the National Program for Palliative Care, for instance, there is a provision under non-communicable diseases where every state can actually ask for funds from the center to enliven the palliative care program in their state. But it entirely depends on the intention and will of the government. So there have been cases where civil society action has translated into the state health department actually writing to the center and saying, hey, listen, we want to train all our frontline workers. We want to do this, and therefore please give us the budget. If you look at the budget that is allocated in palliative care across the country, you'll be shocked at what has been allocated. There are states that have asked for 1 lakh.
Oh.
What can you do with 1 lakh? And there are states that have asked for more, so it's very interesting to see that it's so dependent. So yes, civil society action, I think, is one of the cornerstones of change. Why does palliative care have such a big role to play in Kerala? Why is Kerala such a forerunner in palliative care? It's because the community demanded it. And when the community demands it, the administration has to respond. Now, we run another program called Arohan, which is advocacy skill building sessions for people with lived experience, or people who are interested as lay people to advocate for change. And there we talk about this, and in fact, let me tell you that this is an acknowledged fact, as far as the Commission on Narcotic Drugs even talked about it in Vienna. The NDPS, the Narcotic Drugs and Psychotropic Substances Act of India, was amended to make morphine more available, largely because of the fact that the community got involved. Patients and their family members started writing letters to the members of parliament, to the Department of Revenue, to the Drug Controller General. And that's the first time that patients and families were so deeply involved. And that's what one of the tipping points of the whole thing was. So you're a very powerful group. And there is a Maharashtra state policy. I don't know how effective or how enlivened it is. But certainly we're happy, like Sunanda said, to just support you in any way. And yeah.
And Smriti, I just want to add to Abhijit's concern that, people like you, because I have met doctors during my visits and all, they say themselves that only doctors cannot help. So we need the volunteers. And as Smriti was explaining how and why Kerala is, topping the list. So we need people like you. So I'm just keeping my fingers crossed. So, and I had a very fruitful meeting with the NHM director. I'm hoping by next week we're going to get a go ahead and things are going to work in Maharashtra. So we'll be in touch and we'll share the good news with all of you. Thank you.
Definitely. Thank you so much. Thank you.
So I think we have 5 more minutes left. Ma'am, can we have more examples of high-tech interventions, low-cost of physiotherapy practices at home? I think that's a whole other session, which we'll try and incorporate at some level. In this FCPC session, we haven't, but it is enough demand for it. Perhaps I'm going to ask our wonderful virtual education team, Raj Lakshmi and gang, to please organize something that is customized to people who want to know more about this. So the beauty of virtual education is this. So we hope to share something with you at that point. I'm sorry, at the moment, I don't have anything to share with you that is going to comfortably fit into 4 minutes.
Just to add on, hello, I'm Rajalakshmi. So we have a physiotherapy program, but this low-cost physiotherapy program is something we really need to think about. At least have sessions like this, innovative solutions for it during the program. Definitely, we will keep it in mind and we'll try to implement it. Thank you.
I'll be very happy to share the last video with you. In fact, I'll do it right now. Here you go.
Ma'am, would be getting any resources, ma'am, for the course?
I'm going to let Raj.
Yes, sir,
Hello?
you will be getting it. Am I audible right now? Yes. Okay, thank you. So you will be getting all the presentation which is being shown during the sessions, and also we are trying to send you readable materials connected to the sessions. So we also have a book called Indian Primary and Palliative Care, which will be useful for you to read. So such materials will be shared, sir.
Okay, ma'am. Thank you.
So if there's nothing more, I will take your leave. Thank you very much for joining us on a Friday afternoon. Please do try and come for as many sessions as possible, not just in terms of being certified and getting that certificate in the end, but like we had this really enriching discussion at the end, I'd really like for all of us to get to know each other better so that we can actually make those changes that are needed in our country.